Yeah, you would like to see that stop happening, but you're not going to get that done by actually telling him how to swing. Typically what we'll do is chain that in with like med balls or sort of cable work where he's got both feet on the floor, like in any sort of position, and he's learning how to actually move weight through his feet. So what I found is that you can't really do this on the range. You've got to change how the player manages their center of mass, like on the range. And obviously we're saying like at this point, he didn't have the skill. So we're just showing us an example of what not to do, ironically, even though he can do it really well now. I mean, he's got a really good golf swing. The club face is square with that left arm. And as he starts to make his move down, he might actually be a tiny bit low now. Now you can see he's moving left and it's really early. And what you'd like to see from here is that he'd lower a little bit, and then he'd be able to stay down, but he's actually getting a little bit taller.
So right? I watched this and we know the history of he had the issue with the great toe.
Yep.
What I would do, given the fact, like you said, you want him to maybe increase that shin angle a little bit and come lower before getting taller, which would prevent the lateral drift to his left, or reduce it, would be to look at working, doing a little bit of work on the calf, gastroc soleus, and then because of the issue with the great toe, working flexor hallucis longus, tib post, and the plantar intrinsics, again, just in an effort to offload those structures, to increase his capacity to maintain that a better dorsiflex position. Again, conjecture at this point, would it have made a difference? Who knows? But if you're watching that as a therapist, that the goal is for him to maintain a flat foot contact. That would be the thought process. What are the potential tissues that are restricting him from achieving that position? Anatomically understanding that, obviously gastroc soleus, and then the deep flexors, flexor hallucis longus, flexor digitorum, and tibialis posterior, going around the medial malleolus and into the foot. If we can increase the capacity of mobility through there, in addition to maybe just some easy mobilization of the talocrural joint and the talonavicular joint, that may help to increase his ability to accomplish what he's being asked to do.
Yeah, I think that's brilliant. Like if you can get the structures to all work, in a functional manner, what I would say was, in my ideal scenario, if Jerry had been on site when we were doing this, if we would analyze the physical move, knowing what we were looking for, understanding, the principles and penultimate, and Jerry could identify that. My ideal scenario, and we've done this before, is to get the work done on the structures. And then I would do some sort of an integrated progression of drills, just so Paul could manage it. So you'd have him do a flat-footed med ball throw, heels together, several of them, work that, have him do a flat-footed short club, work to a flat-footed long club, and then progress him to a driver, and in that series, and then test it out, and then have him hit a couple full shots, and then have him go back, and Jerry can check his work and just see how he's responded, and then work him through that progression again. Because one of the things that these guys like is routine. So if he understands, and we do that several times, the third time through, he'll say, "Oh man, that got so much easier," right? Instead of just having Jerry do it and having him go right back to the full swing, it sort of graduates him into it, and he's still learning because he didn't have the body like functioning the way he wanted to. It was difficult to even do the skills. So like at that point, we're addressing skill acquisition, or addressing the physiology, and we're sort of, graduating back into it. So we're, taking care of his confidence. One of the reasons why I'll use a med ball when we do these things is golfers get anxious if the ball's not going exactly where they want. So you can't do the work, without destroying some of their confidence sometimes. At the med ball, they just throw it. They don't really make the connection to the golf swing, even though it's really similar. So from a sort of psychological management standpoint, I'll use something like that as a bridge so I don't affect their confidence, when they're working on their primary skill. When I use a medicine ball and I have guys toss it, it doesn't register to them that they are, doing something with their golf swing, but I'm still teaching them how to manage their center of mass and midline. So that doesn't, like I said, it doesn't affect them psychologically. So, and they are more body aware. So when we do sessions in the gym or we do sessions in the weight room, I am really particular about how they move and how they manage their midline center of mass. When we go to the course, I'm really focused on just what the ball's doing. So that would be the sort of example. We would work, doesn't matter, short, flat-footed clubs. Like I taught Steve Lewis, who is one of Jerry and I's friends. He's a pole vaulter. Taught him sort of how to play golf, and all I had Steve was hit into a net, hitting flat-footed shots. He can shoot in the mid-70s now, and he hasn't played a lot of golf. So I was just telling him, keep your feet flat, make contact, swing through, right? And the ironic part was when Steve had a patellar tendon issue, that was part of his rehab. And he said it actually felt like it was pretty good for him because he got more rotation through his knees that way. But I think hitting into a net and then going onto the range where you're focused on ball flight, changing the focus from an internal body focus to an external, what kind of shot am I hitting, and understanding that and doing that in a way that, the athlete obviously knows what's going on, but as a coach, you're really emphasizing whether it's an internal process or an external sort of result-based thing. So
what Kendall said there in terms of the gradual reintegration of the physical change that we made with the progression of drills and then back into the effort, it's identical to what we would do on the track. When you make changes to the tissue, you want to progressively load those changes with increasing degrees of effort, velocity, amplitude, but you never want to go from physical change to full out effort. Because the brain, the neuromuscularly, the sensory motor cortex, everything needs time to integrate, and that gradual progression is a responsible way to allow for the integration of that new movement capacity to be integrated in a safe manner.